last week we talked about heart, but this week we're going to talk about dermatology. So pretty, very, very different, but I think it'll be interesting. We're going to look at a lot of pictures. Okay, so the first one is SJS or TEN. These are the same. Can you see just the presentation or do you see the blue box?
Only blue box.
You see this one that's moving?
No, not moving.
Okay, good.
Yes, moving. I think it's okay.
Okay, good. Okay. So, basically SJS and TEN are the same thing. They have different names, but they're the same disease. The thing that makes them different is how much of the skin is involved. So I put this picture up top because I think it's the most classic picture that I sent. I think it's a really, really good one for SJS. I wonder if you see a lot of this in Vietnam. Okay. Basically, this is a type 4 hypersensitivity reaction. So it's T cell mediated. And there's actually some really early evidence. We won't talk about this too much, but I just found it interesting that etanercept, which is a T cell drug, might be helpful for this condition. So that's pretty interesting. Basically, the immune system freaks out after there's a new medication and it attacks the skin and mucosa. There's the barrier between the dermis and the epidermis, that layer is what gets attacked by the immune system, and necrosis happens there. So it can be pretty serious because it happens all over the skin and all over the mucosal surfaces. Sometimes this can be triggered by an infection instead of a drug. That's most commonly seen in children, more so than adults. This is pretty rare. It's about 5 million cases per five, sorry, 5 cases per million people per year. But it's super, super scary. So it requires a lot of specialized management, and 30 to 40% of these patients will die within a year of diagnosis. So pretty darn serious. Okay. Risk factors for this are HIV. There's a 12 times increase incidence in people with HIV, especially poorly controlled HIV. Connective tissue disease, cancer. There's a racial predominance. Black and Asian people are more likely than white people to get this, and then female are more likely than male to get this. And then people with renal dysfunction are more likely to get this condition, like with new renal failure, especially if they're on allopurinol for gout. All right, so this graphic is just showing the difference between TEN and SJS. I don't want to get too into it, but basically they're pretty much the same thing, but SJS is less than 10% of the body surface area, and TEN is more than 30%. And then from 10 to 30%, there's like a overlap syndrome. But the pathophysiology is the same, and the treatment is very similar, and the drugs that cause them are the same. TEN, because it's a larger part of the body that's involved, has a much higher mortality, much, much higher. Okay, so basically what you're going to look for is a person comes in with a flu-like illness and a rash 1 to 4 weeks after starting a new medication. Sometimes. So sometimes, especially if that was an antibiotic, like Bactrim is really commonly implicated for this. I don't know if that's what it's called in Vietnam, but trimethoprim sulfamethoxazole. Bactrim is what we call it. But that one is really common, and often that's only a 5-day course. So it's very possible that someone got their antibiotic and finished their antibiotic, and then weeks later is going to develop this condition. The drugs that cause this generally fall into a couple categories. So anti-epileptics, Lamictal, lamotrigine is really common, phenytoin, phenobarbital, carbamazepine, stuff like that, oxcarbazepine. Antibiotics, so Bactrim, like we talked about. What else? Amoxicillin, doxycycline, Cipro, levofloxacin, rifampin. Antivirals like nevirapine, which is an HIV medication. Sulfa drugs, so sulfonamide, sulfasalazine. And then some NSAIDs, but not the ones we use often. So not ibuprofen, not naproxen. It's the ones that ends in oxycam. So pyroxycam, tanoxycam, meloxicam, and then etoricoxib as well. And then allopurinol is probably the highest offender. This one is a gout medication, and this one is notorious for causing SJS, um, especially if someone has a decrease in their kidney function and the allopurinol level in their body increases because their kidneys aren't clearing it, or after increase in the dose of allopurinol. Another interesting thing that we're seeing more and more is that our monoclonal antibodies can cause this. So any of those things that end in mAb that are immune checkpoint inhibitors, they can cause SJS-TEN. It's unknown now if it is the same phenomenon, but it looks very, very similar. So be on the watch out for those mAbs as well. There are a couple mnemonics to remember what these medications are. I don't really like them. If you find them helpful, there are some out there, but I just didn't really find them helpful. I found it easier to group it into categories. So knowing that my anti-epileptic meds, my antibiotics, and antivirals are kind of the ones that are going to cause it. Okay, so let's do some pictures. Oh, sorry, one more thing. The rash starts on the trunk and face and spreads from there, usually. So it starts on the trunk and face. You'll see in the next picture. It starts, you can see those 3 dots. That's how the rash starts. So it starts with these lesions that look like a target. They're called atypical targets because they only have 2 areas rather than erythema multiforme, which has classic full targets. But then the lesions come together and become a big mass. So they start as those little dots and the dots grow and they merge together. They coalesce. We're going to look through some pictures of the earlier stages. So this is kind of an earlier stage. You can see those little target lesions coming together and then the skin sloughing. I tried to use a lot of skin of different color in this presentation, but unfortunately I only have the images that are out there. But you'll see that all of these conditions present differently on skin of different color. So that's just a good thing to remember. You will often see conjunctival involvement, and it looks pretty severe. People often have the sensation of a foreign body, and they have pretty severe conjunctivitis bilaterally, in addition to the rest of the findings. This rash does involve the palms and soles. I like this picture because the picture of the hand, you can see those atypical target lesions. So you can see those little circles with a circle inside. and those are gonna come together. Okay, here's a little more pictures of the earlier stages. These are more of the target lesions, less on the left and more on the right. So this is before the sloughing happens. It looks like this. This is kind of what it looks like in some darker skin. And then I wanted to, or we'll do this first. I wanted to show this video that has Nikolsky sign, just in case anyone hadn't seen it. Let me find it real quick. I have to share my other screen. Okay, this is a quick video, so we'll watch it a couple times, but I think this is a really good demonstration of what the Nikolsky sign can look like.
You have to keep your blankets on. Okay? Right. And when the kids don't know, there's nothing to do there. That's right. You have to keep your blankets on. Okay?
We have the name for this side, right?
No, there's nothing to do there.
Yeah, Nikolsky sign.
It means very easy to remove the skin when we pull it.
What'd you say? Oh, yes, very easy to pull the skin off. Yeah, so if you remember, the skin is getting attacked at the dermis epidermis junction. So that area that joins them together is just dead. So that's why it just pushes off like that. There's very few conditions that do that. So that is a very important sign to remember. Okay, I'll go back to the. Okay. All right. So management for this. Number one, you want to stop the medication that they're on that's causing it. And then if there's an infection that's causing it, you want to treat the infection. The management it involves very, very many teams. It's very complex. So if you're at a small center, it may be appropriate to transfer this patient somewhere where they have all of those specialists. So it affects the mucosa of basically all of the systems. So these people end up needing often the ICU because they often get worse, dermatology, plastic surgery because sometimes they need skin grafts, OBGYN, if they're female, ENT, ophthalmology. So they're really, really complex and they need a lot of medications many times a day. Like the last patient I had with this, she needed eye drops like every hour or something. So you need them to be in a place where they're going to have a really dedicated nurse who doesn't have a lot of other patients. Bacteremia occurs in 30 to 50% of these patients. So treating and preventing infection is really, really important. Often these patients do well in a burn unit because it's very similar to a burn in the way that it destroys the skin. So burn centers, burn ICUs are often very warm so that the patient doesn't lose too much heat. They are very well versed in giving lots of fluids to help the skin because of all the extra losses of fluids through the damaged skin, basically. So they usually do well in a burn ICU. My old hospital did not have a burn ICU. So our threshold to transfer patients to a burn center was 20% body surface involvement. So if there was 20%, we would call and try to get them transferred, usually by air, and it was a whole state over. So it was a big deal. It was like a state to state transfer, but it's really, really important that these patients get all the intensive care that they need. So if you have them in the ER and you don't have a burn center, but there is one around and they are a pretty severe case, I would certainly consider transferring them. The bacteremia, like I said, happens in 30 to 50%. Most commonly, it's Staph aureus, Pseudomonas, gram negatives, and then whatever bugs live in your hospital ICU. And that's just because that skin, that hugest organ we have, is so damaged. These people also need really diligent wound care. So they need nurses and therapists that are really skilled in changing bandages with the utmost care. And they do need their bandages changed like once or twice a day. They need a lot of fluid resuscitation. So if you see one of these patients in the ER, get the ball started early and give them a good amount of fluids. Obviously, watch out if they have heart failure or something else that would make them susceptible to overloading with too many fluids, but give them lots of fluids because they've lost it. Okay, I wanted to show some pictures of the mucosal involvement. This one shows it really well. You can see his lips are sloughing off, and that's characteristic. This one is really helpful too. It kind of shows the sloughing and inflammation and swelling that's happened to this patient's tongue. Um, the thing that is so scary about this and why they need all those specialists is that the skin sloughs off and then you just have dermis and it can actually adhere to each other. So this patient would be at risk when that skin comes off, which it will, of the tongue actually adhering to the wall of the face, to the inside of the cheek. And patients with vaginas can have the same thing. So the vaginal wall will slough off and it can actually adhere to itself and cause all the problems associated with that as well. Um, so for the vaginal involvement, often they will make these custom molds for patients that get placed inside the vagina to hold it open so that it doesn't stick to itself. And they have to be changed daily. It's very labor intensive. This is a later stage of the disease when the skin has started to slough off. It is painful, it is severe, and that's kind of why they get so sick. This is another picture. This person is having sloughing of their epidermis. You can see lots of vesicles and bullae on this patient as well. So those are all skin that's coming off but hasn't come quite off yet. Okay, so tip-offs for this disease. Again, I think this is such a good picture because it shows you can see his eyes are a little red, so he has the conjunctivitis. His mucosa of his inside of his nose is bloody and coming off. His mouth, his lips are coming off. So that I think this is a really good picture to kind of show multiple elements of the disease. So if you ever see that mucosal involvement, it's very, very concerning. And it can happen orally in the vagina, in the rectum, in the conjunctiva, the nose, it can happen really anywhere. It won't always be this obvious, of course, but I think this is a really good example to remember. Okay, let's go on to the next thing. Does anyone have any questions about SJS, TEN?
No.
Okay. Have you seen any cases?
Yeah. But I think that I have so many experience because in Joy Hospital have the burn center.
Oh, it does. Okay, good. That's helpful. Okay, we're going to talk about toxic shock syndrome. This one is pretty rare, but I think it's important to cover. It comes in two flavors. So there's staph toxic shock syndrome and strep toxic shock syndrome. So strep has a much higher mortality, much like strep bacteremia. Those patients are sick. They really are very sick. Strep toxic shock syndrome has a 30 to 80% mortality. So pretty darn serious. Um, There'll be a history that hopefully can clue you in. So what's happening is that there's a pocket somewhere where bacteria are building up, and it's not that this is not a septic type of shock. It's actually that the staph and strep bacteria, if you reach way back in your med school memory, they release these exotoxins. So these are proteins that really basically cause a similar thing to septic shock. So they cause widespread vasodilation, they cause fevers, they cause like a very severe septic-like response, but it's not actually sepsis. It's from these toxins. So it's important, we'll talk about this a little later, but it's really important to try to get rid of those toxins because that's what's causing them to be so sick. Historically, this used to be really associated with tampons. These days, especially with leaving tampons in for a long time. Um, these days, the tampon manufacturers have removed some components that were more likely to cause this, some rayon and other things. And it's more associated with the very heavy duty super tampons. But even so, it's still occasionally associated with tampons, but it's more rare. Other things that can cause it are packing. So if a patient had a surgical abscess that was packed, that can kind of be a nidus for the bacteria to form and gather. An abscess, post-op patients, so post-op from any surgery where bacteria could wall off and build up, and also postpartum patients as well. Um, okay. Oh, also one thing important for us, rhino rockets can cause this too. So I don't know if you guys have those things that you shove inside the nose for nose bleeding, but those can cause toxic shock syndrome. So it's important to remember how long it's been in there and to remove it if you think that's maybe contributing. There's a number of criteria that have to be satisfied for someone to get this diagnosis. So they have to have fever, they have to have hypotension, and they have to have a rash. So those three things. So it looks like sepsis, but there's also a rash. And then they also have to have two other organ systems that are involved. So that can be musculoskeletal, so they can have a myositis. That can be pulmonary. So these patients are really likely to get ARDS. Um, it can come with kidney involvement or liver involvement, so creatinine, LFTs. And it can also come with coagulopathy. So if you're concerned about this diagnosis, send all of the labs that would help you answer those questions. So send a CK, get a chest X-ray. If the chest X-ray looks funky, consider a CT, get LFTs, get a creatinine, and get coags as well, because those things will help you decide if they qualify for the diagnosis and how sick they are. Okay, the rash basically looks like a sunburn. So it kind of has these little dots that you cannot feel. So they're not bumps, but you can see them, but you cannot feel them. Kind of like a sunburn. And they do blanch. So it's very pink, and you press on it and it does blanch. So it does turn white when you push on it. Um, and then they kind of come together as well, and they just look like basically like burnt skin. So it looks like a sunburn, but the patient does not have exposure to sun. So septic looking patient with a sunburn, this is potentially could be what you're looking at. Okay, let's do some pictures. The rash starts flat like this, just looking just like a sunburn. Here's another example on someone with slightly darker skin. It's quite faint here, but if you look closely around the umbilicus, you can see very faint, looks like a sunburn. Okay, this picture, this patient has some edema going on as well that you can see based on how shiny those legs are. But look how pink they are. So they're pink and they're swollen. So I wonder if their creatinine is off or something like that that's contributing to that swelling. This infection or this condition does also come with conjunctival injection. So if you look at this patient's eyes, you can see that they're slightly pink. It's not as bad as the conjunctivitis you see in SJS. This condition is generally not as bad as SJS, and the eyes, the same thing. They don't look as bad. What else? Sometimes in darker skin, it can be really hard to see this change of pink because of how dark the skin is. So one place you can look is you can look at the tongue and you can look for that strawberry tongue, similar to kind of what you would see in children with a different condition. So if you see that, that's concerning. Super pink, those swollen taste buds. And then there's just another picture on the right side of toxic shock syndrome as well. After the rash fades, there's a couple days, and then the whole body desquamates. So it's not sloughing. Like this is not this super scary thing you saw where there's like a raw epidermis under. It doesn't look like a third degree burn like SJS or a blistering burn, a second degree. It looks like what happens after a sunburn, like how the skin peels off. And it just kind of sloughs like that. It looks very dry. There's some more pictures here. The sloughing is often most noticeable on the hands and the palms and the soles of the feet as well. So they'll just kind of all peel. Okay. This is another picture where it's quite obvious of the sloughing as well. So it's like the whole first layer of epidermis is just peeling off, but you're not seeing that super raw and painful skin under like you saw with SJS. It's more just like a snake shedding its outer layer of skin. Okay, questions about that one? Oh, this is a really important point. I don't know if there's been a lot of big studies for this, but you should use antibiotics that are bactericidal, not necessarily bacteriostatic. So there's a lot of movement towards using linezolid and clindamycin because those help decrease the number of bacteria faster than vancomycin. So I always think of vancomycin like, wow, it's vanco, it can do anything. But vancomycin is actually in some of these earlier studies not as good for this condition as linezolid clinda because it takes longer to kill those bacteria. And then the main thing you want to do is get source control. So find where that bacteria are hiding out and get rid of it. If that's an eye incision and drainage, do an incision and drainage. So sometimes this condition can happen with something that looks mild. It looks like a cellulitis or it looks like a small chronic leg wound or something that doesn't look so bad, but then you need to do an incision and drainage because that pus pocket is full of the toxin that's making the patient sick. So you need to open that up, get all that pus out, get all the toxin out so that the toxin stops going into their bloodstream and making them so sick. If it's a deeper infection, then you need to talk to your surgeons and ask them to kindly take this patient to the OR. If it's packing, remove the packing. If it's a tampon, remove the tampon. If it's a rhino rocket, remove the rhino rocket. Hopefully That makes sense. Got to get source control. Okay, questions about toxic shock? It's a nice time for me to take a drink of water anyway.
Just ask about the antibiotic. Did you combination? It means if you use the vancomycin, you will combination with the clindamycin, right?
I wonder if you're thinking necrotizing soft tissue infection. Often for that, we want to use vancomycin, Zosyn, and Clinda, like one of the broadest regimens. This is a little different. What I'm saying is I wouldn't use vancomycin alone. I would prefer linezolid Clinda because they're bactericidal.
Because I read some article, the clindamycin or linezolid can reduce the toxin. That reason, if you give the linezolid, only linezolid, if you give the vancomycin, you need to combine it with the clindamycin. Maybe we will send the article and then discuss later. I think that.
So you can, if you have a neck fash, that can cause this condition. So if you have neck fash, yeah, NSTI, we'll talk about it next. This one.
No, if I think a toxic shock syndrome.
Sometimes the necrotizing fasciitis causes toxic shock syndrome. And necrotizing fasciitis, you want to use vancomycin, clindamycin, and Zosyn.
Usually, how about your experience to treat the toxic shock syndrome? What kind of the antibiotic do you use?
I would use linezolid and clindamycin.
Linezolid plus
Yeah.
clindamycin, right? Okay.
There's also some studies behind using IVIG. But I think that's a little bit more of a ICU question. But just so you know, it's out there. There's some evidence for it.
Okay.
Okay. Okay, we're going to talk about necrotizing soft tissue infection, also called neck fash or NSTI. This is not quite a skin disease, but it's a little deeper and it carries a really, really high morbidity and mortality. So I wanted to cover it. I have seen so many M&M cases for this. So I don't know if you guys have M&M, but M&M is when we do a presentation to all of our fellow doctors about a case that went badly. And I have seen so many about necrotizing soft tissue infections because it's very, very bad and it's easy to miss. It carries a really high morbidity and it can kind of hide. So I think that's why I've seen so many cases go badly with this. Okay, so this condition basically, it's very similar to cellulitis, but it has a much worse prognosis. So it's similar to cellulitis, but there is bacteria that are causing necrosis of the either myositis or the fascia. So, and there's also necrotizing cellulitis. So there's necrosis of the skin, the fascia, and or the muscle that's happening. And that's why people are really, really sick. And that's why it can spread so quickly because the infection can spread quickly along the fascial plane in a way that it can't in cellulitis. So cellulitis, the skin is heavy. It doesn't provide a highway for the bacteria to travel, but the fascia provides this beautiful highway for the bacteria to spread and cause death of all the tissue around it. Okay. Sometimes, as I talked about, sometimes this is obvious. So a lot of the pictures on here are really obvious. I hope that nobody would miss some of these pictures. But sometimes it's not obvious. Sometimes it kind of just looks like a cellulitis. So that's what's scary about this diagnosis is it's a little bit of a wolf in sheep's clothing. It can look like a cellulitis, walk like a cellulitis. Patients don't always have unstable vital signs. They certainly can, but sometimes their vitals are normal or they'll have a tachycardia. So you could easily say, well, they have a tachycardia because they have cellulitis. So I would just try to have a high index of suspicion for this disease and be on the lookout. Every time you have a cellulitis, think, is this just a cellulitis? Is there a chance this is an STI? So there's a couple of different clues. So your clues on exam, obviously there's the bullae, those big black bubbles that you see in the picture to the right, to the top right. That's a great clue. That's not normal. Everyone here knows that. Crepitus, you run your hand over the skin and you feel bubbles. Not normal. Everyone here knows that. Skin necrosis, not good. Everyone knows that. The sometimes cellulitis can have purulence, like thick, creamy discharge. This can have this, surgeons always talk about it in the OR, but it's called dishwater. So it's this thin, still purulent, but very thin and almost gray, discharge that isn't typical of a cellulitis. Another clue is pain out of proportion. So it looks like a cellulitis, but the patient is really uncomfortable. They've needed multiple doses of pain medications. The pain doesn't quite make sense. Like you press on their leg and they like jump out of the bed. Similar to I'm blanking on the word right now. Mesenteric ischemia. So they don't look that bad, but you press on their belly and it really, really hurts. This is similar, right? That's a similar process. The gut is dying. This is a similar process. The skin is dying, the muscle is dying, the fascia is dying. It's really, really painful. Necrotic tissue hurts. So they have this pain that just doesn't quite match their exam. And the other thing that can be really helpful is that it progresses really rapidly. So I think this is a good argument for cellulitis obs. If you guys ever do that where you put a patient, you start them on IV antibiotics and you put them in an observation status so that they stay in the hospital and we watch them for some time, that can be really helpful. So if you get the skin marker, and you mark exactly where that cellulitis starts and ends. On the bottom picture, the pair of legs in the middle, you can see that that person has been marked with a skin marker. So a clue is that what I usually do when I mark people is I'll look at them like if they are really observation and their vitals are stable, I'll mark them at the beginning of my shift and I'll look at them at the end of my shift. So 8 hours later. Obviously, if their vital signs are unstable or if the patient is not looking good, I'll look at them more than that. But if I really do think it's a cellulitis and I'm just being cautious, I'll look at them at the end of my shift. Oh, wow, it's gotten worse. Or I'll tell the nurse, hey, if you see this spreading beyond that line, let me know, because that's very concerning. It'll spread beyond that line. The cases I've seen of this, I mean, it's you mark them and then you go back 2 hours later and it's already spread beyond that line. And it's kind of like exponential. So it spreads a little bit beyond. And then by the time surgery comes down and sees them, it's like all the way up their leg. So it's really, really scary and it spreads very quickly. Okay. Another thing that can sometimes be helpful is you can get imaging. So you can get a CAT scan, you can get x-rays, you can get ultrasound. If you see gas over the site of an infection and there's no way that you can explain it, that's very concerning. So if there's gas and they just had surgery, that can be normal. So unfortunately, that's not super helpful. But if there's gas and they had surgery 3 weeks ago and they're having worse pain, that's pretty concerning if you see gas on their CAT scan. We'll look at a couple images of that too. You can use x-ray. X-ray will only see if there's quite a bit of gas. I would say that CT or ultrasound is much more sensitive. If you see gas in the site of an infection, it's pathognomonic for this. So call your surgeons, get on the phone. There is a score for this. It's called the Lrinec score, LRINEC. It's not very good. So I didn't put a picture of it because it's not as good as the other scores that I've showed you. So just know that it's out there. You can use it. Your surgeons may want you to use it, but it's not very helpful. There are some clues on your labs that should make you more concerned. So, hyponatremia that doesn't fit the patient is concerning. Elevated creatinine is concerning. Elevated glucose is concerning. Elevated CRP and a high white count. Unfortunately, a lot of these things happen in cellulitis anyway, other than the hyponatremia. But if the glucose is high, the sodium might look low. You can correct it. But unfortunately, a lot of those things, there's nothing really super specific. You can get a creatinine kinase if you're worried about myositis. And if that's elevated, that's certainly concerning. Labs are kind of helpful, not super helpful. One thing that can be helpful is trending labs over time. So if you've started this patient on the right antibiotics, you're watching them for their cellulitis, and their white count doubles, that's really concerning. Or their sodium drops, or their CRP goes in 18 hours, it's twice as high. Those things are all really scary and should concern you. If you are worried about this diagnosis, call your surgeon and order imaging. It is not a radiographic diagnosis, it's a clinical diagnosis, which means we can't rely on our imaging. So if you're worried, get on the phone, call your surgeons. The only way there can certainly be CAT scan findings that are very, very concerning, but the best way to confirm this is the best way to treat it, and that's in the OR. So you got to call your surgeons. Treatment and diagnosis are by operation, so in the OR. And then if it's strep, it can cause toxic shock syndrome. So the condition we just talked about can be caused by this if it's a strep bacteria. So sometimes you might have a chronic wound that looks just like a chronic leg wound. Doesn't look that bad, but there can be an abscess in there and release of toxin that's enough to cause toxic shock syndrome. So it doesn't always look impressive. That's what's so important about this one. Know it's out there, be afraid of it, know to look for it, and that'll drastically increase your chance of finding it. I'm going to show some photos. Some of these are going to be really obvious. Some of them hopefully won't be so obvious. Okay, this one you can clearly see necrosis of the skin. Pretty darn obvious. Call your surgeon right now. The one on the left is Fournier's. That is the perineal involvement. Sorry, trigger warning. That is the perineal involvement of this condition. You need to call urology right now. And it can happen to men and women and involves the perineal area with necrosis. Often this is quite obvious. Sometimes it's not. Sometimes it can just look like a cellulitis in that area. So maintain that high index of suspicion. Sorry, I should have said this on the first slide, but every single time I've seen this in a patient, it's been in a poorly controlled diabetic. I have not seen it outside of someone having really, really high glucose to feed that infection. So those really high glucose levels feed that bacteria, or maybe I'm just seeing that the infection is causing the high glucose, but diabetes is number one risk factor. So risk factors, diabetes, diabetes, diabetes. There's also some weird stuff like marine organisms There was a case of this happening to a very, very healthy young man who was a surfer who got a cut, went surfing, and got a case of this caused by a marine organism. So there are some kind of interesting things to look out for. There's Clostridium perfringens in soldiers. So there's kind of some interesting risk factors, but the vast majority of the time, diabetes. Okay. The one on the left, this was a case of bilateral thigh necrosis. So this person needed really extensive surgeries and skin grafting. You can see really obvious skin necrosis. This is another example. These are those really obvious bullae. If you see I've never seen those. Usually the cases I've seen of this are more subtle. This person is a late presentation. So they've probably had symptoms for a while, and this is happening very, very late in their course. That fluid is necrotic fluid that's just dead. That's that dishwater fluid they're talking about. The one on the left, I feel like you can see it a little more because the one on the right, a little more blood, necrotic fluid, but the one on the left, dishwater, gray, nasty looking. Sometimes it's not so obvious. So sometimes it can just look like this. This to me, I don't know if you guys see a lot of cellulitis. I see a lot of cellulitis. This kind of just looks like a cellulitis, but this could be neck vash. So keep a high index of suspicion. Make sure you think about this diagnosis. When you see a cellulitis, just think to yourself, is this neck vash? Can I convince myself that it's not? And if the patient has enough risk factors or they don't look so good, or if I'm worried, I will just put them in obs. So I will ask the next doctor coming on for me, hey, can you look at this person at the end of your shift? Just make sure they're not getting worse. Just to make sure that they're improving on antibiotics as we expect for a cellulitis. Their vital signs are not abnormal. They're not having really, really bad pain. Look out for those things. If you're worried about a cellulitis, you can always do an OBS. You could also put the probe on. So wheel the ultrasound over. This is going to be helpful for everything these days. So this on top, there's the arrows that also explain, but on top that fluid between the tissue is called cobblestoning. So that's just fluid. But the thing that's scary is the other arrows that show the really, really bright is air. So that's gas. That's gas in the tissue where it should not be. If you just did a lidocaine infiltration or something and you see that, it can be normal. But if this patient hasn't had any violation of the skin by us, that's not normal. Okay. So really often when I have a cellulitis that looks kind of bad, or I want to make sure there's not an abscess, I put the ultrasound probe on to make sure there's no abscess. So this is the other thing I look for too. I just make sure there's no gas. This is a CAT scan. So CAT scan can be helpful. Remember, do not let CAT scan delay you calling the surgeons. So if the surgeons are on the way home or on the way in, do not say, just kidding, can you wait an hour? I'm going to take him to CAT scan. Don't do that. Just get the surgeons to come in because if they're concerned, they'll take the patient to surgery. But in this CAT scan, you can see the legs look very, very different. So one is clearly swollen, lots of edema, lots of fat stranding. So there's a severe infection there. Sorry, I gotta drink. But the thing that's most concerning and the thing I want you to note is where the arrows are. So there's gas in there. Those super bright spots, those are gas. So that is concerning for necrotic infection. This looks like a myositis because it's not in the skin, it's in the muscle. So this is a necrotizing myositis. So this person needs to go to the OR and get a cut down all the way to their muscle and needs to get that washed out. And they need antibiotics. This is one more picture on ultrasound of the gas as well. So this is a case of Fournier's. and you can see that there's just gas everywhere. So gas is super, super bright, and it has these dirty shadows. So if you know what a lung ultrasound looks like, it kind of looks like that. And you really should not see that in the skin, in the soft tissue. Air is the enemy of ultrasound, so you can't see deeper. And you shouldn't have that. I mean, bone, you're not able to see past bone with ultrasound, so that's normal. But if you put the probe on skin and muscle and you can't see all the way down and there's no bone in the way, that is weird. So this is a super, super obvious case of necrotizing myositis. I mean, that whole muscle has basically been replaced with gas. This is terrifying. I don't know what happened to this person, but hopefully that is helpful. Any questions about, where did it go? Any questions about, oh my gosh, sorry. This slide. Nope. This slide. Any questions about, oh, sorry, antibiotics. So treatment. As I talked about, vancomycin, Zosyn, Clinda, or meropenem is actually being used. So carbapenems are being used with some good effect. So vancomycin, Zosyn, clindamycin, like huge antibiotic regimen, or meropenem. And that's just because there's a lot of bacteria that can cause this. And then the other thing is surgical debridement. So antibiotics, surgery, antibiotics, surgery, antibiotics, surgery. Okay, I really hope that was helpful. Next week, someone please bring a case, please. I will be so appreciative. It can be cardiac or it can be skin. Whatever you saw at work and you thought was interesting, even if it's not like crazy like the cases we saw, even something more obvious, like even if you just want to talk about a cellulitis or something, that's okay too. Does that sound okay? Thank you. Have a good week.
Bye bye.